Well, let's move on then to some other fun topics for your 2015 renewal. We're going to talk about 5 strategies. We're going to hit on 5. The first is PBM, Pharmacy Benefit Management. The next is some spouse contribution strategies that are becoming more and more popular in our market and nationally. The third bullet, as Patty likes to call it, is managing the mischief. This is how we play I call it whack-a-mole, right? That there's abusive things that come up every year that we have to tighten our contracts up to make sure that your plan isn't wide open to some abusive practices that reveal themselves in new ways every year. And then we'll talk a little bit about wellness and then a stop-loss gap analysis. So we're going to start with PBM. Does it ever feel like when you're looking or trying to have a conversation about your existing pharmacy benefit management contract that it feels a little bit like you're playing darts blindfolded? And you're like, well, I think that AWP discount sounds good. I mean, 18% sounds like a good number. I guess that would be good, right? And it's no wonder we all kind of feel a little nebulous about trying to understand and then feeling like I don't have any good solid ground under me in trying to negotiate a better deal because I don't really know where all of the money is hidden under my existing contracts to know where to push, right? So even the Partners Group with 13 benefit consultants who've been doing this for a lot of years, we felt this way too. Because PBM contracts, you figure it out, and then there's another trick, right? There's other places that money is hidden in your contracts. And so we worked collectively with our other C2 firms, which there are 7 of us nationally, and collectively we're the 5th largest independent brokerage in the country. We worked with a company called RX Benefits, and RX Benefits is led by ex-Caremark executives who understand this business. And we hired them to do a full PBM marketing for us and negotiate contracts with 2 PBMs, Caremark and Express Scripts, that are best in class and take advantage and actually expose, right, the areas that we know are taken advantage of commonly in other PBM contracts. So for our groups that are self-funded, where we have an opportunity to carve out pharmacy, we really encourage you, if you aren't already a client of the Partners Group, to allow us to do a PBM repricing for you. We've done it for many of our existing clients. We've done it for prospects. And the average savings is 20%. When you consider that 20%, I'll come back to this slide, 20% of your overall medical claims is pharmacy, that 20% savings on 20% of your overall spend is a 4% overall claims advantage. And that is significant with very little to no member disruption. So you have to be self-funded in order to carve out your pharmacy. If you're fully insured, you get the bundled deal. But if you're self-funded, you do have that option of carving out pharmacy. So our C2 contracts, these are new to us this year. We just rolled them out to our first clients January 1st of this year. And we've just had our first quarter experience reports where we've done kind of prove it. We've asked RX Benefits, our C2 partner, to prove it on a retrospective basis for our groups who implemented our new C2 contracts the first of the year. And what we found is that all of the savings, if we reprice them under the old contracts, have been at least what was promised under the marketing process, if not more. So it's been exciting for us to see that kind of real life examples and savings for our groups who've moved there. So, even if you are with a carrier who has, you think, oh, well, I've got this bundled program, the carrier will give you all the reasons in the world. Don't carve out pharmacy, right? We need that data in order to do effective disease management. Well, we can have an argument about effective disease management another day, but they are getting their data from a third party already, right? It does, and in some cases, that third party is Express Scripts or Caremark. So moving to our contract still doesn't mean any disruption. It means better pricing for you, better contracts. So don't be deterred by a first barrier, right, that you're going to get, especially from an insured carrier, because there's likely some revenue streams in that existing relationship that obviously they don't want to get rid of, okay? So here is just an example of a financial analysis. This was based on a carved-in national carrier. What that means is this was probably, it's not UHC, but a UHC-like scenario, maybe a Regents, maybe an Aetna, where it is an ASO model where everything's bundled. And in this case, the savings to move to CVS Caremark was 21.52% of overall spend. And for this group, that amounted to $425,000. So we're seeing lots of opportunities in this area. All right. So the next strategy that is becoming more and more popular and something to consider for your next renewal is how much do we charge for spouses, right? It used to be that, employers were committed to both providing a rich employer contribution to employees and a rich employer contribution to dependents. For several reasons, financial pressures being one, and two, just the changing work environment and the changing demographics of working American families, that most families have two working adults in that family. And I'll give you a real life example of a shared client of Karina and myself. This was a blue collar group down in Coos Bay. They have about 180 employees, ocean towing and barging, family run organization since its roots, and had always been very committed to providing no cost coverage for their employees and families. Well, word got around in the community that this employer was very generous. And so we started hearing that in annual open enrollment meetings for neighboring companies, school districts, the hospital, they were a slide in their presentation that said basically, if your spouse works for this company, we'll give you $200 to opt off of our plan because their coverage is free. And we went, oh, well, that was really not the intention of being generous, right? We did not want to be the source of insurance for not only our employees, but the employees of the whole county, right? And so unfortunately, because that ended up being the case, we needed to put in a premium structure that said, if you have a working spouse and that spouse has an offer of coverage from his or her own employer, it's going to cost them more to join our plan than if they don't have an offer of other coverage. That spouse surcharge arrangement was specifically to ensure that their employer, the employer of the working spouse, was their first and primary source of insurance, rather than them being incented off their plan and this group being kind of the source of insurance for everybody. And we did that 4 years ago. Immediately, the per employee per month cost, not the volume, because of course your volume of claims would go down because lots of people dropped off the plan and went to their own employer's plan for coverage. But our per employee per month cost went down, or per member, sorry, not per employee, per member per month cost went down 15%. So, and that was because if you talk to Case Escher, who's the director of our data analytics department, he will tell you that the highest risk group or population in a group is spouses. From a cost perspective, average claims cost per member. And there's lots of reasons for that. And in this case, the costs went dramatically down the year that we put in the spousal surcharge, and really they have beaten trend every year since. So here's what we're seeing in terms of not just here at the Partners Group at our clients, but what we're seeing nationally. And the source for this data was just the new survey that was just released by Towers Watson. And it basically says that here's what's in place for 2014, and here is the percentage of employers who are considering adding this strategy for 2015. So the first is just that they're increasing the costs for spouses at a higher rate than they're increasing the cost for employees. That if I've only got so much money in my pot, I'm going to keep my contribution as high as possible for my employees, but there's less to go around for dependents, so my dependent costs are going to go up. So that's currently in place for almost half employers, and an additional 19% of employers are planning that for next year. Spousal surcharges, when other coverage is available, is in place for now. Almost 25% of employers, which seemed like a high number for me, but we've been talking about it for a while. And with an additional 15% of employers considering it for next year, with the average surcharge being around $100. Okay. The next is requiring spouses to purchase health insurance through their employer first. So not just making it cost more, but saying if you don't buy coverage from your own employer, you're not eligible for ours. So that's a little bit harder line that isn't quite as popular, but that's in place in about 10% of employers, with an additional 13% of employers considering it. And then in place for 2014 is for 2% of employers is that they simply don't pay for any portion of a spouse's coverage. It's 100% paid by employees. And that's less common. Generally, we still see some level of subsidy of spouse premium, but you can see that 2%, it's in place for 2% of employers in 2014, with an additional 5% considering that. Okay? Any questions? Yes, Wendy.
So, Sarah, that sounds great. Talk about operationally how they validated and
yes.
scored and how they
I know. So the question from Wendy is, that sounds good from a financial perspective, but how in the world would you manage this, right? And so what this employer did for the employer that I gave the case study for, they, as a part of open enrollment, they don't have an online enrollment system, so theirs is done entirely by paper. So it's an additional enrollment form, and it's called a spouse domestic partner coverage certification. Thank you. Spouse domestic partner coverage certification, and they have to attest on an annual basis that either they don't have coverage or whatever scenario they fall into that would determine the appropriate spousal surcharge. And on the bottom of that, it basically says, if your circumstances change, you must notify human resources. They don't go hunt people down. They aren't, this is a small community. They know when people are lying, but they don't do anything. They really just go, this is going to be kind of an honor system method. It's, it says on there that if you lie, you could be faced with dismissal. But that's the way that they do it. And if you were on an HRAS system where it was a self-serve model, what you would do is basically add this to your decision tree or election tree process with your HRAS system, where they would ask the questions about availability of other coverage. Good question. All right, so let's talk about a couple examples of some mischief going on. These are the hot topics for 2015. It's new and different every year. But the first example is air ambulance. And so full disclosure, my husband is an air ambulance pilot. I think he's a really good guy. I don't think he's a total crook, and I don't think the company he works for is awful. But there are some bad apples out there, and we have seen evidence of that in our claims. And what's happened is that before ACA, there were typically financial limits in our contracts that said air ambulance is going to be paid up to $10,000 a year, right? Or up to certain number of equal amount to ground, 100 miles of ground transportation. There were internal limits in our contracts that limited the payment for air transport. That went away with the Affordable Care Act, because anything that is emergency, and air transport is considered emergency, can no longer have any sort of dollar limitations on it for either in-network or out-of-network. And air ambulance companies don't contract with insurance companies. And so what happened is that created this whole new opportunity for some air ambulance companies that have taken advantage of this. I saw a claim last year for a large self-funded employer of mine in Eugene that incurred an air ambulance transport claim for $440,000. That was for the air transport alone, with a $36,000 charge for parking the airplane. So, and we, with a lot of research, determined that this was not unusual for this particular air transport company, and that they are very aggressive in their marketing and how they treat their patients, meaning really drawing them in as a client, that they will pre-authorize with a plan for, saying our estimate for the transport is $15,000 and turn around and bill $400,000. The problem is that without a contract, right, if you're an insured plan or if you're in fully insured carrier at risk for your own claims, there's nothing that that insurance company or that plan administrator can do to really hold that air transport company's feet to the fire and limit what they're billing, right? They can bill anything they want without a contract. So then that puts the plan administrator in a position where, well, okay, well, if we limit the payment to $70,000, that means that air transport company can balance bill my member $300,000, right? And that would be devastating. So it puts the plan sponsor in this position of, I don't want to put my member at risk for that type of financial event, but I also need to do what's best for the plan and be under my fiduciary responsibilities under ERISA. I have to manage the expenses of this plan. So a couple things that you can do to limit this exposure. One, which we've seen many insured carriers and plan administrators do locally, is put a limit on the payment of air ambulance transport and limit it and basically say we're going to pay it as a percentage of Medicare allowable. That are allowable for air ambulance transport, and you could say we're going to pay 400% of Medicare allowable. So you feel like that is a reasonable threshold. You could set that at 250% of Medicare. You could really set that percentage wherever you feel comfortable to make sure that you're paying a fair rate to the air transport company, because these aren't, unnecessary transportations generally. But you're also managing the expenses of your plan. In the case of our employer with the $440,000 bill, because of a union contract that didn't allow us to put any limits, they paid that claim in full. So this is an opportunity for us to work together, look for those, what mischief is happening in the marketplace, and let's look to make sure that we've got the contract provisions in place to protect the plan. The other opportunity is end-stage renal disease. So this is another example where kidney dialysis clinics, like air transport companies, do not contract with insurance companies. As a result, they can charge whatever they want for these services. And we've seen large national companies coming in and purchasing smaller local kidney dialysis clinics. And the costs for kidney dialysis going up and up and up. Kim, I'm going to put you on the spot. I don't want to, but I know you've been intimately familiar. Just what is an average monthly expense for kidney dialysis?
It depends on the area, but we have a large claimant for one of our clients that's up in Alaska, and it ranges around $40,000 a month.
So $40,000 a month that can go on and on and on and on. Obviously, this is necessary treatment. This is life-saving treatment. If they don't get the treatment, they will likely not survive. So this is, it's not something that you could not cover, right? It's not something that we can postpone. It is something that we have to deal with on the cost side. So a strategy that, again, many of our fully insured carriers are putting into their contracts, and a strategy that we have deployed with many of our self-funded clients is a strategy that basically says if you're diagnosed with end-stage renal disease, which is one of the common diagnoses that results in kidney dialysis, that under Medicare rules, you become eligible after your diagnosis, after a set amount of time, to be enrolled in Medicare. Medicare contracts with kidney dialysis clinics. So once someone is covered by Medicare, it automatically limits what that kidney dialysis center can charge for dialysis to their Medicare contracted rate. So that becomes an immediate benefit to the plan, because all of a sudden, we, the plan sponsor, the self-funded plan, the fully insured plan, remember you're at risk, so you care about how they're managing your money, that allows us to significantly reduce payment on those claims. Any of our other consultants in the room who've put this in have an example, Mark, of what your costs did after Medicare cost savings? I know Gary's got one, but he's in Chicago.
Yeah, I think locally we see around 30,000 average,
Mm-hmm.
and there's two predominant providers that have a monopoly on dialysis, and that's why you see them not contracting with any of the carriers. They make their money on the commercial plans. They do not make money on Medicare patients. Therefore, they look for the commercial plan, and that's where they're going to make their significant margins. I think in just general numbers, we see about 30,000 per month for your commercial plan, and somewhere south of $10,000 a month on a Medicare allowed amount.
Mm-hmm. Yeah,
So
that
we're
sounds
talking
significant savings.
Significant savings.
Yeah. So what you do from a plan design standpoint is many of the carriers are communicating to individuals who have been diagnosed with end-stage renal disease the benefit of enrolling in Medicare. Their benefit is that they have double coverage, right? It now coordinates between Medicare and your employer-sponsored plan, so significantly reducing their exposure to out-of-pocket costs because they're double covered. And in some cases, carriers and administrators are refunding the cost to be enrolled in Medicare Part B. Now there's some dialogue about how you should handle Medicare Part B premiums, but in many insured plans, they're now basically paying the members' costs to be enrolled in that program to incent their enrollment in Medicare. Because if they aren't enrolled in Medicare, there is no, you could still reduce your payment to that end-stage renal disease or that dialysis clinic, but the member would be on the hook for any balance billing. So they are really protected if they're enrolled in Medicare, as is the plan, obviously really reducing your exposure to those. So those are two examples. Next year there's going to be something new, but those are two examples that we're really working to tighten up our contracts and make sure that our employers aren't exposed to excessive billing in those areas. And so we've got some wellness slides here that I think most of you are familiar with, our wellness kind of A/B plan design that we're really recommending. And I see some clients in the room who already have wellness programs in place. So I'm going to skip this slide and just basically give you the quick snapshot. Basically, this is encouraging our employers who don't already have a wellness plan in place to consider designing your plan, so premium contributions and plan design, deductible levels, to incent participation in a wellness program. National surveys are showing that employers are starting to transition away from participation-based programs to outcomes-based programs. We aren't seeing that a lot here in Oregon. That's more a national trend. But we are seeing more and more groups step into participation-based wellness programs where your contributions, your monthly contributions for enrollment in the plan, and in some cases, in addition to that, plan design, are predicated on your participation in biometric screening events, completion of health risk assessments, and engagement in disease management or health coaching programs. This slide shows that what we can do, the Partners Group, through CASE's business analytics team and our TPG analytics, if for any group that is self-funded and we are getting your claim level, line item detail information, those claims feeds from your administrator, that we then have the opportunity to stratify the risk of your population and identify the individuals who are at highest risk of becoming your next big claim. And the reason that it's important to always have that forward view into who's next, right, is that your large claims, they generally turn over year to year, right? And so if we only manage the people who are large claims this year, we're not doing anything to manage our future costs. So this is just a reminder about what's available here at the Partners Group if we get your claims data from your administrators. The next 3 slides are an example of a meaningful, just one example of a wellness tool that we're rolling out through C2. This is called Active Care, and it's really interesting. It's specific to help members with diabetes. And it's basically a new glucometer, right, that basically you can test your blood sugars. It goes into this device that then sends out alerts to however you want to set it up. It can notify the disease management nurse. It could notify your personal physician. It could notify a spouse. If it's a child with diabetes, it could set up where they're testing at school, and if all of a sudden their blood sugar goes out of whack, that notification goes to you at work, right? Because if you've got a child with diabetes, you know that we don't really know. Are they testing during the day? You know, what's happening? Did they skip lunch? You know, and for a fragile diabetic, it's even more important. So this type of technology, where it's basically smartphone-based technology, gives you real-time information to help an individual manage their diabetes. And if they're having a diabetic emergency, it will even call 911. So this is something, it's a wellness tool that is available through one of our C2 contracts or our partner, and would be available really for any of our groups to try. The cost of it is basically paid on your self-funded plan. You pay for it like any other medical supply. So you're paying for your diabetic supplies through a self-funded plan through your claims. So basically that you would pay for this very similar to that, but under a separate bill. So just fascinating new technology that's out there and available on the market to help us manage chronic conditions and manage fragile risk in a real-time, meaningful way. The last thing that we'll touch on for things to consider for your 2015 renewal, again, if you're self-funded already or if you're considering moving to a self-funded product, is don't forget the details on your stop-loss contract. The stop-loss contract can feel like a commodity, right? Just say, okay, well, we're looking at 3 things. We're looking at what's the paid basis, right? Is it a paid contract? Is it a 12-15? Is it a 12-12? Is it a 36-12? Making sure that those numbers are what we want it to be. We're looking at the rate, and we're looking at the deductible and attachment factor. There are all sorts of provisions in a stop-loss contract that make a difference, right, to making sure that there's no gaps and opportunities for our clients to have unexpected costs. So just like our RX Benefit Solutions through C2, C2 at a national level contracted with 6 stop-loss carriers to negotiate contracts without gaps, with no holes in them, to make sure that on a macro level that we've created contracts that don't put our clients at risk. And they include some options. So terminal liability options, so basically you have to opt into that, but you can choose to say, I don't know what's going to happen 9 months from now, so I'm going to just choose to insure my tail of claims right now. Or you can choose to say, you know what, I don't want terminal liability, I'm just going to renew at the end of the year. No laser provisions, so making sure that there are no surprises at renewal, that if you end up with a hemophiliac that's on your plan that is going to cost the plan $600,000 year over year over year over year, that if in your given contract that stop-loss carrier can't non-renew and can't say, next year we're covering everybody but that member, or we're covering everybody at $100,000 deductible, but that member is going to have a $500,000 deductible. These contracts, there's no opportunity for a stop-loss carrier to do that at renewal. Rate cap guarantees. So these contracts different carriers that we've contracted with through C2 have different levels of rate caps. So even in a terrible year, you're not going to get that 80% renewal increase. So has anybody in the room had an 80%? I had one last year. Wasn't good. So rate cap guarantees, I like them for the right group. Sometimes they're a waste of money. It depends on how much they're charging you for that future guarantee. So again, it's a risk-reward analysis, but it is a nice offer to have as part of your stop-loss guarantee. No cost refunding provision. So, in some years with a stop-loss contract, you won't have any large claims. And you'll look back at that and go, if I had only known, I would have chosen a higher deductible, right? Because I paid a lot for that coverage and didn't get anything for it. Well, you're going to have years, right, under a stop-loss contract where you paid a lot of premium and didn't get any benefit. Optum is one of our C2 carriers that is giving us a refunding provision that basically says if you do better than expected, that based on a formula at the end of the year, we're going to give you a portion of your premium back if you renew with Optum. And that's been, typically there is a charge for having that provision in your plan, and with our C2 contracts, that refunding offer is made available to our clients at no charge. So it's been very interesting to our clients to give you kind of one more thing to consider as an alternative. And it's actually been effective at helping to give some market leverage to our renewals to say, okay, well, this client, if they move to Optum, they have an opportunity to get $60,000 back at the end of the year. And so it kind of forces the hand of the existing carrier to know that, all right, well, I actually have to come in under the Optum rate in order to give them some advantage, right? If I meet the Optum rate, then Optum still has this advantage of a maybe win at the end of the year. So it's been a really interesting process to go through some of our groups' renewal. And then the value-added services. So Transplant Networks is one of a value-added service for one of our stop-loss carriers. And then our ambulance management, wherever there is mischief, a new vendor pops up, right, to help us manage that mischief. And one of the new vendor partners that we've found in trying to solve for this air ambulance issue is actually a vendor that Mark Mills found. And this is a company that is having some success in negotiating case rates with air ambulance transport companies and doing prior authorization before the transportation occurs. And in this case, a stop-loss company, because they're the ones who are going to benefit from reducing that $400,000 claim to a $100,000 claim, because that's basically all their dime, that stop-loss vendors are the right people to go to say, hey, why don't you pay for this service since you're the ones who are going to be benefiting from it, or at least share in the cost of this service. And we've been very successful in getting them to bear those costs as well. We thank you so much for joining us this morning. And as you think about, we love to host these morning sessions, and we hope that you walk away thinking a little bit differently about your plans, but these are really for you. So if you have a topic that you want us to focus on, let your consultant know what you'd like us to focus on. We are happy to do it. We're committed to these morning sessions. We hope they're valuable for you, and it's our pleasure to host. So thank you all.